Welcome, everyone. I'm really pleased to have you here this evening with us. This is our opportunity tonight in the Department of Neurosurgery here at Mass General to share some of the advances in spinal neurosurgery that are occurring. And we have two really wonderful experts with us, key leaders in our spinal neurosurgery division. Those include Dr. Ganesh Shankar, who is an MD and a PhD, who is an assistant professor of neurosurgery here at Mass General, who joined our faculty just a couple of years ago after training here at Mass General. We also have, and are fortunate to have with us, Dr. Shin, who's an associate professor of neurosurgery here and director of our spinal deformity and spine oncology program. And so these two speakers are going to really give us an overview of important aspects of spinal neurosurgery and some of the opportunities that we have going forward to continue to make a difference in the quality of life of individuals with spinal disorders. As chief of neurosurgery, one of the things that I've been so impressed with over the years is how much spinal neurosurgery impacts quality of life. It takes individuals who are in pain or discomfort or having difficulty with mobility and completely changes their life as they undergo those procedures which stabilize the spine and improve functionality, and also help us to address important problems in a wide variety of domains, including degeneration, oncologic disorders, and many other aspects of spinal neurosurgery which are so critical. So just a couple of reminders, and then we'll launch right into the talks. At the bottom of your screen, you'll see a little button that says Q&A. And during the seminar, at any time, if you think of a question, please go ahead and hit that button and you can type it in to the Q&A comment box. And then that will be held in reserve. And when we get to the Q&A portion of the seminar, we'll actually go through those questions. And we've actually had a few of them that have been sent in ahead of time as well. So again, the Q&A button at the bottom of your screen, feel free to use it at any time. Yeah, you won't interrupt the flow of the presentation or anything like that. And lastly, as we get through the talks and we get into the Q&A, one thing I think it's just important to know is we won't be able to, because it's a webinar format, we won't be able to directly see you or speak to you, but nonetheless, we'll try to really get the information across through the Q&A process through the chat box. So with that, I'm going to go ahead and launch in and turn the time over to first Dr. Ganesh Shankar, who's going to be discussing some important aspects of not only his practice, but what we're trying to do here on the service.
Thank you, Dr. Carter, for that introduction. It really is a pleasure to be here together with my partner, Dr. Shin, and sharing this time, this hour with you all on this call. I just want to make sure that everyone can see my screen here. Okay, good. So I first wanted to start by saying that as much as we've have tried to help you all as patients on this call, either through operative approaches or non-operative approaches, I want to really underscore how much we've learned from all of you about how we can do our jobs better and how we can improve in the future in terms of managing patients who present with spinal disorders. And so with that, I wanted to start my discussion with what does modern day complex spine surgery look like? And really there's a couple of key tenets that we deal with when it comes to complex spine pathologies. And the key categories of clinical problems that land in this domain are trauma, infection, and tumor, as these pathologies can really change the structure of the spine, the stability of the spine, and can compromise the way the spinal cord or nerve roots function in a way that it causes pain, or it can cause weakness and numbness or difficulties with basic functions such as using hands and walking. And in these cases, we really think about how we can address these pathologies through open approaches, through minimally invasive approaches, but basically it's whatever it takes to deal with the pathology and reconstruct the spine to stabilize it. And that really highlights our basic goals. In spine surgery, we try to improve the quality of life by decompressing the spinal cord or nerve roots to return function in terms of weakness or to reduce pain, and also to stabilize across abnormal motion. And that's where the instrumentation comes into play. And even though we're really good at doing those two things, I know we can still do better, because I still get asked these common questions either before surgery or even after surgery, which is, why did this happen to me? Did I do something that caused this? Did I inherit this problem? And how can I prevent this from happening again? And the basis of these questions, which are very well founded, come back to one of the basic primers that we all use in modern day spine surgery, which was written by one of my former mentors at the Cleveland Clinic, Ed Benzel, is this book that we all know in terms of how we do our job, which is the Biomechanics of Spine Stabilization. And I would argue that given our inability to really answer those key questions that are constantly raised, we still don't understand the origin of why those problems occur in the first place. And so we're not very good at really understanding the biology behind spine pathologies. And that leads to a couple of things that we still commonly deal with in spine surgery and complex spine surgery, which is failure of the hardware, bones not fusing completely, problems at the level above or below where we performed a surgery, and as patients may have experienced continued surgical discomfort or lengthy post-op recoveries. And this really gets at our incomplete understanding of the biology of spinal disease. And one of the most common, and not even really complex, but one of the most common problems that we deal in spinal surgery is degenerative spine. And these really encompass problems that occur from arthritic changes, where either bone spurs are forming or ligaments are thickening, and the final endpoint is pressure on nerve roots or the spinal cord, and that causes significant disability in the form of pain, fatigue, weakness, numbness. And our goal in these cases is to relieve that pressure by removing this diseased tissue that's overgrown. And if we take this very common problem that we take for granted on a daily basis, where we are just removing this tissue, we still are left asking, why does this happen in the first place, and how can we study this problem? So this is an aerial view of MGH from Google Maps of how our campus looks right now. And it really gives a snapshot of how we get to start answering these questions with the resources that we have. That blue line right there indicates my walk from the operating room to the lab in the Simkes Research Center and back. And we can constantly go from bedside to bench and back to really reiterate the process of how we can do our jobs better by understanding the biology better. And this walk is 6 minutes round trip. It encompasses all the complex spine pathology volumes and basic degenerative spine pathology volumes that we continue to learn from. And we get to go across the street and work with some of the greatest and most talented minds in biomedical research and engineering, who aren't just thinking about spine problems, but maybe thinking about any other problems, but may have overlap with the types of issues that we're trying to address here. And so this is a picture of what my daily life would look like. On the top is me hanging out with Dr. Shin, and that is a very common scene that you'll see. Dr. Shin trained me when I was a resident, and I'm fortunate enough to come back and now be his partner, and we get to deal with some of these spinal pathologies together and really have these in-depth discussions about how can we do our job better and address these problems in greater detail by really understanding the biology and some of the other parameters that he'll talk about shortly. And we get to take our questions back to the lab, and this is Evan Burns and Margaret Sten, who are great technicians who work in our lab and are working feverishly. This is Dr. Mohammed Hatsipasek. He's one of our senior neurosurgery residents, very talented, MD, PhD from Yale. We were lucky to match him here for the training program. He's an engineer at heart, and he has been assembling some very interesting questions to really address that basic question, very interesting approaches to address that basic question that I raised in the beginning. And so here's an example of the pipeline. We get to take tissue from the operating room and then bring it to the lab to run it through our pipeline using molecular biology techniques that we specialize in over in the research area in terms of understanding DNA, RNA, proteins, tissue architecture. And here we can see what that ligamentum flavum looks like under the microscope and all the different fibers. And from there, we can actually culture the cells. And we believe that we can start to really appreciate what is it that's driving some of these pathologies. And I'm just going to give you a little bit of a highlight as to what could be resulting in this thickening of ligament and bone spurs that could be driving this pathology forward. So here is an example of one of those thickened ligaments taken directly from a spine. And what we can see here is that there's a region where there's been some form of injury in the past, as shown by a decrease in the dark staining. And this area is then filled in with cartilage. When we zoom in and look a little bit more closely, what we see is that within that area of injury, we see a cocoon of cells that seem to be activated. And when we look even closer at those cells, what we find are a special type of cell that's actually been noticed in other parts of the body that get activated and then enact a program of fibrosis. And we believe that these hidden cells may actually be driving the processes that plague a lot of spinal pathology that we see. In order to understand this further, Dr. Hatzipasek is actually engineering very complex techniques to apply this tissue to the same forces that are seen in the spine. He is taking that tissue from the operating room. He's developed this machine that you're seeing here on your screen, 3D printed all the custom parts, and engineered it in a way that he can take that tissue and apply it to the same cyclical forces to see if he can reverse engineer the same patterns of fibrosis that are being seen on a daily basis from the patients that we are removing this tissue from. And this is going to give us some very important insights as to what drives this process, and then more importantly, how we may be able to reverse this process. The importance of understanding the biology of what drives spinal pathology is really underscored by the fact that we still think we can do our job better than what we're doing right now. I think we do a really good job of relieving pressure on the spinal cord and nerve roots and stabilizing, but there's still things that we can do better. Together with our collaborators at MIT, we've been developing 3D printed screws that one day we may be able to use to actually give local drug therapy to address the biology that's driving that process. So some examples of that is, instead of just putting in plain screws that we use routinely, we would use these screws that can actually instill local antibiotics if somebody has an infection, or reduce the risk of having an infection occur on the hardware itself. Local chemotherapy when there's tumors, so that instead of just removing the tumor surgically, we can actually get better control of microscopic disease even after we're out of the operating room. Or possibly even instilling bone growth agents to help increase bone density and fusion, especially for patients who may have sustained fractures from brittle bones, is to try to use this as a way to get local bone growth as well. And coming back to the question of degenerative changes, if one day we understand the biology of why that happens in the first place, we might be able to do injections that surpass what we do currently, which is just steroids and anesthetics in the epidural space, and inject compounds that may actually be able to dissolve away the spinal stenosis. So I know this sounds a little bit far-fetched, and I can just hear the question, is it really no surgery for dealing with a problem that is classically considered surgical? But it all depends on the biology. And I just want to give an indication that what once seemed like fiction back even just 5 years ago is something that's coming to reality. And that's our understanding of how mutations drive and classify disease. This is a project that I've worked on now since 2014, and really harnessing some of the resources that we have around here in Boston through our collaborations around the world. And we have appreciated that there's certain recurrent mutations that happen in brain tumors. And we realized that if we can classify those mutations, if we can identify those mutations in a rapid timescale, we may actually be able to diagnose brain tumors in a more minimally invasive fashion, or perhaps even in a more rapid timescale. This project has since matured to include many more mutations that one would find even in other forms of metastatic tumors, such as melanoma. And making use of one of my favorite childhood games, Tetris, this is an assay that's now being vetted as a potential clinical diagnostic that can help really segregate what is the tumor type that is being found within brain imaging or spinal cord imaging in a way that we might be able to identify these tumors, not from an invasive biopsy, but rather from a liquid biopsy, from a lumbar puncture, or perhaps even a blood draw. And so here's an example of a patient who had a problem in the back part of their brain and ultimately underwent a surgery to diagnose this. We were able to collect fluid in the form of cerebrospinal fluid. And even before the surgery happened, we knew that this patient had a certain form of a tumor that would respond well to chemotherapy and radiation. And so the hope is that one day we would be able to diagnose problems like this that we may find along the spinal cord with just a lumbar puncture. And that's important because if we can avoid a surgery for diagnostic purposes, that it would allow for earlier initiation of chemotherapies, radiation, and really avoiding that post-op recovery period that patients still go through. So there is hope that by understanding the biology better, we may be able to really push the ball down the field. And so a vision for the future of spine surgery is that we'll continue doing what we do in terms of decompressing neural elements and stabilizing across abnormal motion, but through our understanding, a deeper understanding of the biology of what drives spine disease, we can develop targeted interventions that directly address these key drivers, as opposed to working on just decompression and stabilization. So towards a more minimally invasive but maximally effective way of approaching spinal disease. So I'd be happy to take questions later on, but for now, I would like to transition over to my partner, Dr. Shin, so that he can provide his thoughts as well.
Great, that was terrific. So it looks like we'll turn it over to Dr. Shin now.
Great. Well, thank you, Dr. Carter. And I'd like to also thank my colleagues who helped organize this event tonight. Even though I cannot see you, I did scroll through the participant list, and it's great to see so many familiar names. And I'd like to say Happy New Year to everybody. And for those who I don't know, because you're a patient of Dr. Shankar's, I hope you find this session informative. So, you know, I think it's tough to follow Dr. Shankar in almost any aspect of life, especially when it comes to research. But I'm just going to give an overview of some of our advances here with regards to complex spine surgery and research here in neurosurgery at MGH. So this is just an overview of sort of where we are right now. And I just wanted to start off with the slide because I just wanted to demonstrate our portfolio of research that we do. And I love that Google map that Dr. Shankar showed, because not only does it show you know, how close we are to all these great resources, but you know, it speaks to actually just one component of what we do. And I know there's a lot on the slide, but I just wanted to show that in general, everything down the middle of the slide, these are common themes that we study. And they revolve around predictive analytics using artificial intelligence to try to understand recovery from surgery, complications after surgery. We study our outcomes all the time. We're also using advanced imaging technology to do studies looking at body composition and fat and muscle to see if that's predictive of complications or outcomes after surgery. And we also have a robust laboratory research component to our portfolio, where we are doing investigations with spine tumors and spine stenosis and degeneration, as Dr. Shankar suggested. In spine surgery, the two main areas that I'm particularly interested in is specifically in oncology, cancer, as well as deformity. And these are the themes that are really universal to both. But when we talk about cancer, we are looking at cancer survival. We study metastases, the frailty of a patient, how strong is someone for surgery. We're looking at their nutrition. And we launched a study looking at what's called sarcopenia, and that's basically, what is that underlying health of that patient, and how does that translate to how that person will do. When it comes to degeneration and deformity, we're also using a lot of these risk modeling to predict complications and really to provide better education and counseling for our patients so that we can be better at recommending surgery and also designing and developing operative treatments. So just a couple of background slides. Many times patients ask, what is a spinal deformity? Do I have a deformity, and what does that mean for me? And why are you recommending this type of operation? When you hear terms like kyphosis, it really means what the spine looks like. It's bending or twisting in an abnormal way, sort of front back, okay? And so this cartoon shows someone looking at someone from the side, and kyphosis this is what prevents you from standing upright, and I'll show you some examples of that. Scoliosis is a curvature of the spine that we typically see not only in children, but also in adults. The reason why this is all important is because the rates of spinal fusion are increasing dramatically in the United States. If you look at insurance data, Medicare data, over the last 2 decades, there's a significant increase in the rise of spinal operations, particularly in spinal fusion operations with people living longer and an aging population. But that presents a number of challenges. Here, this is an example of someone who presented with scoliosis. They had a previous operation done somewhere else many years ago, but then came to see me because they were having so much back pain and leg pain, and they could not stand or walk. And I know that the audience isn't familiar with looking at an X-ray, so I'll just provide some highlights here. On the left side, this shows the screws and the rods and the devices that were placed before. And you can see that what happened over time was that this patient's spine curved above that, and the patient started to lean towards the right side, causing a lot of pain. And this patient subsequently with me underwent a revision operation with a combined anterior and posterior spinal operation. And you can see here, it is much more extensive, but we're able to correct the scoliosis and the deformity that was causing such severe compression. But these are difficult operations, they're challenging. And a universal question that always comes up is, am I strong enough? Am I healthy enough to undergo this operation? And does it really have to be that invasive? Well, not every spinal condition needs something like that. But I think with the context of what Dr. Shankar and I do, especially at a place like the MGH, we do tend to see very complex problems where patients are really struggling with these factors that impact their quality of life. But not every operation is like that. Here's an example of a very common operation. In fact, an operation that many of you here may have had, either by me or Dr. Shankar, which is an ACDF. It's an anterior cervical discectomy infusion. And this is typically done for neck pain, arm pain, for nerve or spinal cord compression. And in its most basic form, we can do this at one level, taking care of one disc in the spine. But we also can take care of multiple levels now with improved implant technology, better biomechanical strength of the implants. And now we can do this with 2, 3, 4 levels. But then we have situations like this where it's difficult to do things that we often take for granted. For example, on the left, this person can't even look straight. Their chin is literally on their chest. and they cannot look straight. And you can just imagine, even if you try right now, if you put your chin on your chest, you can imagine how are you going to eat? How are you going to drive? How are you going to bathe? How are you going to clothe yourself? And this person had severe neck pain. And this x-ray is upside down, but you can see here that there's a fracture in the rod here, okay? This patient had surgery before and had so much neck pain that the muscle here, the trapezius muscle, became so tight that did not get better despite massage or physical therapy. So surgery is not always the answer because complications can happen. And one of the themes of our research is really trying to develop ways to not only predict complications, but also to minimize them. When the cervical spine, for example, deforms or becomes kyphotic, meaning that chin gets closer to the chest and it's harder to move because of so much neck pain, a lot of different things happen with regards to the angles of the spine, and we have a lot of sophisticated ways to measure that, but that's how we determine whether we should do an operation from the front part of the neck, from the back part of the neck, or combined approach sometimes with the front and the back. There are a lot of considerations, and patients often ask, how do we decide whether to do one or the other? Because each approach has a different complication profile. And this is something that patients don't necessarily see all the time, but it's sort of activity behind the curtain. This is what Dr. Shankar and I do maybe late at night or the morning before, or planning a case, thinking about a case. We're thinking about and we're talking about, what, the cervical lordosis is not so great. I don't know how much I can do, or I don't know how much I can improve by just going from the front alone. I may need to do something combined. And so these are some of the thought processes that we have, but it's not an exact science. This is just a video showing that in a normal case, the neck is upright, but over time, what ends up happening is that the head position changes, and you can see what happens to the spine there. So what do we do? Well, we can do operations. I think many of you will probably recognize this. This is the inside of the Lumbar operating room. And this is an operation, a complex operation we're doing on the back part of the neck for complex deformity. And we have the tools now. We can use things like intraoperative CAT scan, using different computers, and something like a surgical GPS to help us identify where we need to go and how deep to go. This blue marker represents how deep I'm going into the vertebrae of the cervical spine. And why is that important? It's important because the airway is right here. The esophagus is right here in front of the spine. One of the arteries going to the brain is right next to that blue marker. And obviously the spinal cord is in the middle. So something that I always emphasize in the operating room when we train our residents is, there are a lot of landmines around where we're trying to operate. And it's really, we have to be very mindful of how to minimize those complications. And now we have advanced tools at MGH. This is a 3-foot scoliosis x-ray now that we can use intraoperatively. Not many hospitals in the country have this, where we can really assess how much correction and how much improvement we're getting in the operating room. As many of you know, and I'm sure have experienced, we love to get x-rays when you come see us in the office and when you're in the hospital. And the reason why is we like to compare exactly what those x-rays look like compared to what we had at the time of surgery when we did the correction. And this is just an example. This is someone who had a chin on chest. You can see they're lying down. The chin is nearly on their chest. But then with the surgery, now we've been able to restore the balance, and now the neck is more straight. Whereas before, it was really angling almost down to the floor. So these are extensive operations, very invasive, but can provide significant pain relief and improvement in quality of life. And this is just another example of that. You can see the chin is almost on the chest, curvature of the spine. The head should literally be up here, and that's the result we get after a corrective surgery like that. Now that's cervical, but what about lumbar? Here is a single level lumbar issue. This patient has stenosis as well as a condition called spondylolisthesis. And basically, there's severe degeneration in the facet joints here. There's severe stenosis and compression of the nerve roots. And this is a common problem that many people face. And the typical solution for that is a single level decompression and instrumented fusion, otherwise known as a TLIF. It's an operation that Dr. Shankar and I do quite often, and very effective to alleviate back and leg pain. But that's a simple problem. Now, what happens when you can't really stand up because the pain is so disabling? And I'm sure that many of you have either experienced or maybe have a family member or a friend or just have seen someone walking down the street who's not necessarily walking completely upright. They're walking hunched over, maybe with a walker or a cane, and they're having a great difficult time standing upright. And there are ways to fix that with operations when we carefully select patients, but again, they're not easy. And this picture on the right, I took this when I went to go see this exhibit at a museum with my kids. And this is basically showing the brain and the spinal cord and all the nerves that arise from that. And I love this picture because it just shows, you know, how fragile the nervous system is and what we're trying to do. Obviously, we're trying to correct the spine and the alignment of the bone, but we have to be mindful that the spinal cord and the nerves are traveling through all these bony channels. And it takes a lot of energy to walk. It takes a lot of energy to stand upright. And I had a video here, but I guess not working anyway. And this just shows that. This is a patient who underwent multiple operations, and you can see there are a lot of screws, there are a lot of rods in there. But basically what happened years later was that the rods broke across. And this is an x-ray looking at that patient standing up from the side, and you can tell they're not standing upright. And here you can see the fracture in the rod again. But after corrective surgery, I'm able to reconstruct the spine and all the way to the right, get that patient back standing upright again. So the question becomes how to fix it. And I'm sure many of you are wondering, well, should it be fixed? And this is something that we talk about. I was in clinic today, and it's a conversation I was having all day long, is, you know, we can recognize the problem, but should it be fixed? Am I strong enough? Am I healthy enough to do that? And that's the problem. Well, this launches into one of the projects that Dr. Shankar and I are now launching. And again, this is just one aspect, one component of that portfolio that I showed earlier. And this is really this is an ambitious project. We sort of liken this to it being sort of like a startup. But, you know, we're trying to use artificial intelligence and machine learning techniques to take these x-rays and to develop predictive models to help us determine, one, which patients really should have surgery and which operations really give us the best outcomes. And we have great help. Again, Dr. Hadzapazic is one of our star residents. We have outstanding residents here in our program. And he's currently in his research time, and he is helping us develop this methodology, as well as a research fellow, Ellie Masad, who is exceptional and also has been really key to helping us design this work. So what is this? We've written a lot of papers looking at all these different angles and some of the angles I showed you before. A lot of these measures that we do in planning surgery are not so accurate. And in fact, they don't necessarily predict outcomes so well. There's a lot of fine print here, and it's not important to know what that all says, but the fact that most of these are in red is really telling the reader that most of these metrics that we use as surgeons to plan surgeries, they're actually, they're not that accurate. So what we want to do is we want to take imaging that you get when you're getting x-rays or someone else is getting when they come to the MGH. We take all of that, we take their presenting symptoms, we feed that into our algorithm that we've developed with artificial intelligence, and we correlate that, match that to surgical outcomes so that we can really develop patient-centered quality of life outcomes assessments and complications avoidance. There's a lot of work that's being done now with programming these computers and developing these algorithms using artificial intelligence to help identify these x-rays, but also categorize the images that we're obtaining to help predict these outcomes. This is just some representative work of what our team is working on right now. So this is how we do it. We take the raw data from the x-ray, and it's not a screenshot of the picture. It's the raw data that we take, we process that, and we program the algorithm to essentially give us those parameters that we're interested in. So instead of me doing this by hand, we're trying to train the computer to develop these angulations and these parameters and to come up with predictive models of how much correction we can actually get and if those corrective maneuvers will actually result in a positive patient outcome. The advantage that we have here at MGH is that we have this. We have the patient-reported outcomes, we know the pain scores, and we know how patients do after surgery. Because we want to improve upon this. This is just a working example of what we do on a daily basis. We get the x-rays, you come see us, we get the x-rays, we talk about it, we go through it in the office, but we don't really get down to the angles and the measurements in the office. We plan all of this in anticipation of surgery, but we want to make this better. We want to make it more accurate because we know that the more accurate we are, we can plan surgeries better and make them safer. So just to wrap up, future directions, where are we going with this? There's a lot to be discovered here. And I think that there's a lot of value in the questionnaires that you're filling out on the iPads when you come see us, because we're learning. We're learning from our experiences. We're learning also from the surgeries that we're doing. And ultimately, we are advancing surgical techniques. We're introducing technologies such as the computer navigation, robotics, and all of this is really meant to supplement and help our decision-making tools. And ultimately, one of the things that are really driving Dr. Shankar and I is really, as he mentioned, is we want to minimize the complications but maximize the benefit. And how do we use the latest in technology, including data science and analytics, to help us make those decisions so that together, we can collectively make those decisions together to produce the best possible surgical outcome. So I just want to emphasize that it's all about the team. We've got a great team. And I think that, with a great colleague like Dr. Shankar and with Dr. Carter's leadership as a chair of neurosurgery, we've already been able to do so much. And I think that, like many of you have experienced, whether it's for tumor or deformity or stenosis, there are so many questions. And I'm sure many of you have questions as well. And, we are on the same journey together trying to find answers to those questions. So thank you very much. That wraps up my slides. And I will turn it back to Dr. Carter.
That's great. Thank you both for that overview. We had a few questions come in, and I just want to reassure everyone we will stay on time, but we do have a few minutes for these experts to address a couple of these questions that have come in. I'm going to start off with the one which was from Daniel Tracy. This was a question that I actually had as you were presenting, Dr. Shankar, and he asks, have you identified the cell types of the hidden cells that drive fibrosis? And if you have or if you haven't, could you maybe tell us a little bit about how you would do that?
Yeah, so this is it's a very important question, obviously very precocious to even pick up on that subtlety there. The challenge in interpreting the literature that precedes us is that people have characterized ligamentum flavum in the past and have noted that there are certain cell types that are within that tissue. The problem in really understanding what those cells represent for the human disease is that that's a single snapshot of what that tissue represents in that given time point. No one has really experimentally taken that tissue and tried to drive that system forward. And so that leaves us with the question of what gives rise to these cells that we believe are the drivers of fibrosis. Are they stem cells that give rise to this myelofibrosis type? It's characterized by an expression of a protein called SMA. Or is it that there's a certain fibroblast that then goes backwards and then becomes a fibrotic cell? And those are things that we don't know the answer to because we can't see the sequence of events when we just take a tissue sample from a patient and look at it under a microscope. So this is why that engineering of that system to experimentally test this hypothesis is going to be so critical in seeing if we can follow the fate of a cell as it leads down a road of fibrosis. So right now, we don't know the answer to that question, but that's exactly what we need to understand in a very granular fashion so that we can understand which cells we need to turn off so that we can drive the system backwards. One thing I will say, though, is that when we, in terms of things that we know, just from our own experience with patients, is that when we see ligamentum flavum that's thickened, that tissue can actually melt away if you lock a segment in place with a fusion. Even if that's not taken out surgically, decompressed surgically, that thickened ligamentum flavum can over time regress. And that indicates that this is a dynamic structure. And so if even for things that might be cartilage and phenotype or increased or decreased elastin content, these are tissues that are constantly in flux. And if we can understand the cell type that's driving it forward towards fibrosis, if we can shut those off, we can try to drive it backwards towards regression.
Thank you. That's helpful. You know, one thing I will just interject here is it seems to me that you and your team, you're devoting significant time and effort to this area of investigation and inquiry. And I guess I would just say to our audience, one of the unique things about a department like this is that we charge our surgeons, like you've got with Dr. Shin and Dr. Shankar, to not only be the top clinical doctors, to be able to execute and do the things that are done in all parts of the country today, but they have that extra special charge to go to the next level and create the therapies of tomorrow, whether it's through SpineNet and AI and machine learning, or whether it's identifying an important cell that causes fibrosis. And that investment of time is driven by not only the personal commitment of the two doctors that we have here, but also the support that we get to allow them to develop these investigations. So Dr. Shin, I was curious on your presentation, and you showed a slide, which I might just share my screen briefly. Here, you showed this slide which showed this picture of the nervous system. And I think it's important when we see the spine, we see bones, we see screws, we see stabilization, but the impact on the nervous system is tremendous. And I guess the question that has come up from the audience is, when a person has nerve pain, what are the effects of stabilization on that nerve pain? And then what are situations where a person might have, if they have ongoing pain, what are the ways that some of the technologies that we have today that we didn't have 20 years ago can help us tease that out in terms of the after effects?
No, that's a great question. And I think what is very difficult is, the imaging studies that we typically review and analyze, including the MRIs and the CAT scans, they're very good at showing us two-dimensional views of the nature of the compression of the nerve. And clearly, many patients, like many of you, have come to see us when the pain is there and it's severe, and it may have been there for 2 weeks, or it may have been there for 2 years or more. And oftentimes our role as surgeons is to maximally decompress that nerve as much as possible by removing whatever debris is there, whether it's ligament, disc, stenosis, a tumor, or even a cyst. These type of pathologies, they cause severe compression on the nerve. And the best thing that we can do is literally remove that and make sure that that nerve is completely decompressed. That being said, after surgery, there is somewhat of an unknown, because for many patients, the response to the decompression can be variable. And that's because we just don't know, just by looking at the nerve, we just don't know really how damaged the nerve is from the years or the weeks of compression that were there. So for many patients, they'll have relief of sciatic pain. Arm or leg pain will get dramatically better. But oftentimes there are other components of the nerve compression that may linger. And that is very frustrating, not only for patients, but for us as well. And that may manifest to persistent numbness, tingling that just won't go away no matter what you do. Despite physical therapy, it may be difficult to walk. There are many different aspects of that nerve recovery process that are difficult to tease out after surgery. It's just because we don't have a great sense now of how to assess what the actual condition of the nerve is and what it was before surgery. We do have some testing with an EMG and nerve conduction test that our neurology colleagues help us with, that can give us some idea of what is going on with the physiology or the activity of the nerves. But oftentimes that also is not so satisfying for either a patient or for us as well. So that is definitely an area where there needs to be a lot more research, and we do have colleagues that also specialize in specific nerve disorders.
It's a follow-on question. One of our participants, Kevin Winders, asked a question. He talked a little bit about how he'd had a prior fusion secondary to a procedure that was undertaken. Now back to exercising daily, playing some golf. But the question comes up, and this speaks, I think, a little bit to not only the surgeon's intelligence, but also your work on artificial intelligence. How worried should a patient be about fusion failure in the future? And how do some of these techniques that you've been working on get us to a point where we can actually, ahead of time, make or design a construct that will be resistant to failure? And so maybe you could kind of couple that patient question with a forward-looking view about planning the best fusion.
Yeah, absolutely. First of all, it's great to see Kevin on, and thank you for that question. And I'm glad you're able to play golf. That's fantastic. But you're right. I think that any patient who's having spine surgery, especially with instrumentation, the concern is always, when can I get back to doing things I love to do? And am I going to be hurting myself? And can I do things like that? And I think those are things that we think about when we're trying to design these constructs. How many levels, what type of screws, are we going to put cement into the screws? Dr. Shankar hinted that at some point we may develop biologics through the screws that go into the bone that may enhance the healing process. Right now, we're limited because after surgery, a common restriction that we're telling everyone is to limit their bending, lifting, and twisting, and it's a slow process. And it's not because we're necessarily worried about the instrumentation failing or pulling out or breaking. It's just because we know that too much activity will cause a certain amount of pain. But you're right. Well, one of the major issues in spine surgery is the need for revision surgery and additional surgery after that primary operation. Daniel Tracy asked, what about single level TLIF? Can that be done minimally invasively? It can, but the rates of revision operation, whether it's open or minimally invasive, they're about the same. And that's a major problem because, you come in for one operation, the last thing you want is to come back for another repeat operation because of the disc above or below. And that's why we're trying to use these analytics to help not only plan the operations, but to design the constructs so that, if we know that there is a certain percent likelihood that the next disc above or below will fail within 2 or 5 years, that is very powerful information that we could use to make a decision together about whether to include that level or not. And I think that's where we struggle with, patients so much as trying to come to that decision of, should we include that? Should we not? Should we wait? Because no one wants to come back, even though that does happen a small percentage of time.
That's very helpful. I think we have time for maybe one or possibly two more questions. Here's one that either of you might take on. All of us in normal daily life, we've seen advances in technology. We walk around with our iPhones, and it's a mini computer that we have right there on our phone, and we didn't have that 20 years ago. There are so many other advances. If you were to, maybe comment briefly, you're working on game-changing technologies. What do you see coming in the next 5 years that you think might be really altering the way things are done in the clinic, and how might Mass General be leading out on that? Go ahead, Dr. Shankar.
Yeah, I think we already discussed some of the emerging technologies, but they may not be ready for prime time probably for another 5+ years. I think within the next 5 years, technologies that already exist that we could make use of is really understanding how patients do after surgery. One of the things we've talked about with some of our colleagues who think about wearable technologies is having patients wear things like Fitbits or Apple Watches that will count steps and really see their fitness before surgery and see how things have changed after surgery and follow their progress to be more quantitative about it. It's really one of the challenges that we have, and I always ask my patients, how would you define success after surgery? And that's, every patient is different. But one thing that's common amongst patients is that they want to get back to doing the things that they like doing. And a good surrogate for that is how many steps can people walk? How mobile are people? It's just an everyday function. And that's a very low level piece of data that in the modern era we can acquire and see how well we do for our patients with the approaches that we take.
That's a great thing. Pre and post-operative analytics like that, I'm sure would be very helpful across the population to understand the impact of these. In my role as department chair, I do see data that come across from the entire Mass General Brigham system. And when we look at the pain scores and the outcome scores of our patients treated here, I'm really pleased by the division's impact on the individual lives of patients through these procedures. One of the things that I think is an interesting notion is that of trying to make a surgeon scientist have kind of a viable opportunity to create, innovate, and think of new ways to help patients. And Dr. Shin, in kind of the leadership role that you have in spine and some of the young people that you're working with, like Dr. Hadzapazic, whom you've mentioned, what are some of the most impactful ways that patients can help out in that process?
Yeah, I think it's a collaboration, and I think that we rely on support from our patients to help with our research endeavors, and we have great residents like Dr. Hadzapazic, who is committing several years of his residency training to study this further, because he also he's not going to be a trainee forever, and is going to want to pursue additional training and establish his role as a surgeon scientist as well. And a lot of times it goes back to my sort of what I pitched before of us thinking of ourselves as like a startup. I think that, we have all these great ideas and we have incredible raw talent. And it definitely takes support to help get these ideas off the ground. And I think it's really exciting to partner with patients who have not only experienced what it's like to go through spine surgery, but whose lives have been positively affected and impacted by that. So I think, for any of the patients that we've treated in the past or will be treating, I think it is a true privilege. And I think, I think I can speak for Dr. Shankar. It is really a privilege and an honor. And it's something we take very seriously because, as surgeons, we're not stagnant. We're constantly growing and evolving as well. But part of that evolution is not just what we do in the operating room, but it's thinking about the patients we're going to be treating 5-10 years from now, whether it's for cancer or a degenerative issue. And I think having a team and inspiring young leaders is a key component to that mission.
Well, I want to thank you, Dr. Shin and Dr. Shankar, and also Sarah Gaylord for all of your help organizing this session. It's been a privilege to spend an hour with you as our audience. There's a virtuous cycle, which is patients come here and their lives are substantially altered as they go through a process of healing. And our desire is to, as you said, maximize function and quality of life and getting back to doing the things that one loves. And in that virtuous cycle, some patients will be able to participate and help us out with these exciting research and innovation endeavors. And for those that are listening in today and participating, I want to thank you for joining with us in that concept. And Sarah Gaylord is always available for additional information about our projects and our programs, and I'm happy to discuss those with you. So again, thank you, everyone. I hope you have a good night and appreciate our speakers. And we'll provide another update in a year or so. But thank you again.